If you are overweight, obese, pre-diabetic, or have type 2 diabetes, this protocol is for you. Only 12.2% of American adults are now metabolically healthy. 86 million adults in the US have pre-diabetes, and 70% of these individuals will eventually develop diabetes. Being overweight or obese is the main factor for progression to diabetes. The best way to reverse diabetes is to not get diabetes in the first place, because your chances of heart disease, cancer, and death are increased even as a pre-diabetic. Our protocol offers real hope and transformational change to patients who would otherwise be consigned to a lifetime of medications, doctor's visits, and suffering. Welcome to ReverseDiabetes.md.
Hi, I'm Dr. Gurpreet Pata. I'm a board-certified anesthesiologist, interventional pain physician, and addiction specialist. Today I'll be talking a little bit about one of our protocols that we utilize to help patients with obesity, prediabetes, and diabetes type 2. Obesity is far more complicated than just simply calories in and calories out. It's far more than just simply eating less and moving more. Obesity is affected by a whole host of underlying neurophysiology and neuroendocrine systems. Obesity is something that has hijacked the endorphin system, and it results in a substance use-like disorder. It's not a classic addiction, but it reflects addiction. Obesity is not going to be solved by eating less. It's not going to be solved by moving more if the underlying issue is a dopaminergic reward system, which is hardwired into humanity. There's no amount of habit formation that can steer a patient away from a dopamine flux. When you have dopamine and its release, and the brain is hardwired for that, that's simply an itch that demands to be scratched. That's not something that the average patient, no matter how good their habit formation is, no matter how desirous they are to not participate in food consumption, that they're going to be able to get away from. You have to treat obesity in a similar way to how you treated addiction. You have to extinguish the precedent cues, you have to figure out a way to provide satiety, and you have to substitute in a time-based manner the stimuli that would cause a person to consume. The pathophysiology of the problem is that obesity is not the problem. Obesity is the result of a maladaptive behavior. It's reinforced by engineered food, by hyper-processed food manufactured by large food conglomerates that have specialty in addiction, that have specialty in engineering, and know what it takes to make food consumption go up. Obesity is just the visible symbol of the underlying disease. Food activates two distinct primary pathways. There's a nutrient set point pathway, and then there's an endorphin pathway. The nutrient set point pathway is a homeostatic set point for certain minerals, for certain types of protein, for certain kinds of liquid consumption. And there's a set point. When you're missing a certain amount of salt, your body hungers for it. When you're missing fluid, your body hungers for that. When you don't have enough protein, your body hungers for that. There's a separate pathway that gets activated, and that pathway is the reward system. The reward system was originally designed so that when a paleo-human encountered a nutrient-dense food that was extremely flavorful and extremely delicious, the human would gorge on that food, because at that point humans were only eating a few times a week. And if they identified something that was incredibly nutrient dense as represented by its flavor profile, then they would gorge. Unfortunately, that system has been hijacked by our large food industry. The dopamine reward is a activation of the nucleus accumbens. Foods high in fat, sugar, and salt, combined with flavor enhancers, mimic the neuropsychology of this opiate reward, and it's very similar to the effect in the dopaminergic system to substances like cocaine, alcohol, and opiates. Now, compulsive overeating, which is a little bit different than just simply obesity, is more classically recognized as an addiction disorder. It's my opinion that obesity utilizes the pathway, but it's not in the same way. Certainly there's maladaptive behavior, certainly it fulfills some of the DSM classifications, but it's incomplete. Dopamine is the recognized neurotransmitter for classic substance use and abuse disorders, and it is also the neurotransmitter that regulates food reward and the hedonic aspect of appetite. So the classic addiction model does not explain obesity. It probably does explain compulsive eating, but it does not completely explain obesity. The Yale Addiction Scale shows that not all obese individuals exhibit food addiction. So this is significant because some people have said, well, all food is addiction. And I would contend that yes, there's a dopamine activation, but it doesn't rise to the level of addiction other than for compulsive eaters. That doesn't change the pathophysiology, and it actually makes it more easily treated because we don't have to deal with the withdrawal aspects of the classic addiction. The more likely mechanism is that overconsumption of food is akin to goal-directed drug taking under the control of the ventral striatum. It becomes habitual over time due to learning and memory, and the antecedent clues cause that to occur, and then there's a loss of executive control. A classic example of this is that if you eat breakfast routinely, then you will routinely eat breakfast. And you can break that habit, but you will jones for that breakfast. So you're not going to go into withdrawal, but you do have a loss of executive control. And if you encounter a breakfast item in your immediate vicinity at breakfast time, you'll probably eat it. Acute administration of drugs of abuse produce a rise in nucleus accumbens dopamine. Now that becomes important later because we know that dopamine is involved with addiction. And when you sensitize the mesolimbic dopaminergic system, you get increased salience, and then you have motivation toward that drug-related cue. And that's going to become important in a second here too. The development of addiction is associated with a decreased striatal D2 receptor, and that creates a reward deficiency syndrome. So that's I need more of this drug because I'm missing some of my D2 receptors. And then when I do get this drug, I get a flux of dopamine that's pretty high, and it produces a hedonic response, and when I'm missing it, I'm anhedonic. Now what's interesting is that rodents exposed to high sugar, high fat, and a combination of high sugar and high fat develop behaviors that resemble addiction. They go into binge eating, they have compulsive food seeking, and they have some withdrawal symptoms. So there's an overlap. Using a sugar addiction model, an opiate-mediated withdrawal syndrome is demonstrated. So if you use a naltrexone-like substance on a population of patients, you can reduce the consumption of sugar or carbohydrate. There's also some good PET imaging studies that document nucleus accumbens activation after an extraordinarily high glycemic index meal. And so on radio-labeled glucose and on radio-labeled sugars, we can show that the nucleus accumbens lights up. It's the hyperpalatable food that I believe probably causes an addiction-like syndrome. Animals are presented with either high sugar or high fat diets, eat excessively, but don't really gain weight, as they offset the increased intake by eating less food. But if you combine the high fat and the high sugar, that's what gets you weight gain. We believe that obese patients' relationships to food is more similar to a behavioral addiction, like pathological gambling, than the classic substance addiction. That doesn't mean that it shouldn't be treated. It doesn't mean anything like that. But the big difference is there's no clear-cut withdrawal mechanism. There is a harmful use with maladaptation, but it doesn't meet the criteria of dependence. It's the refeeding cycle in obesity. It's driven by external cues. These are anticipatory cues which change the pancreas, and the patient, because of the change in pancreas and the change in insulin loading, loses their fat metabolism adaptation. And so they constantly forage for food. They constantly forage for sugar because it's readily available. And when they forage for sugar that's readily available, they constantly dump out insulin. And the constant insulin dumping causes fat accumulation because insulin is a fat storage hormone. The real issue is the role of big food. So in 1977, right before the 1980 dietary guidelines, there was a big push to get rid of natural saturated fat. And to replace that natural saturated fat, there was then a push to increase processed food. And the increased processed food permitted an increased amount of carbohydrate consumption. And so it's that replacement of carbohydrate for natural fats that has caused the increased insulin release, and the chronic high insulins then lead to obesity. And that habituation is a feedback loop. The big thing is that since the 1960s, the average farm is now being monocropped, and it's being hyperproductive. And when it's monocropped, nutrients are depleted from the soil. And to increase the hyperproduction, you have to treat it with fertilizer. And unfortunately, what that does is it creates product from the farm that lacks nutrients. It lacks vitamins, it lacks significant minerals, and it creates a tremendous shift in the micronutrients that are in the food themselves. Maximizing food quantity comes at the cost of nutrient density, and food becomes blander and blander and blander. Big Food recognized this, that their food was not as tasty as it used to be. So they embarked on a process of making their food tasty again. And they did that by engineering. They figured out synthetic flavors and synthetic colors that tricked the brain into thinking food was nutrient dense. And unfortunately, nutrient dense food, the human body is hardwired to overconsume. And so, exposed to extraordinarily nutrient dense appearing food, the body artificially consumes, and in doing so, overconsumes these carbohydrates. And in doing so, produces extraordinarily high levels of insulin. And when those insulin levels are sustained high, that causes fat deposition in the liver, which then causes insulin resistance. So the eating behavior is driven by expectations of pleasure, because humans crave flavor. And the Big Food has figured this out. It's allowed them to create extraordinarily hyperpalatable, highly processed foods that activate the reward system, which increase food consumption, which increases the bottom line of Big Food. This constant signaling barrage promotes a nearly constant grazing behavior. And slowly we've gone from about 2 meals a day up to about 6 meals a day. The brain's perception of nutrient value is distorted by the synthetic flavors that big food has created. Food palatability stimulates appetite. It reduces satiety, it increases refeeding, and it causes an excessive energy intake, disproportionate to what one would expect. It doesn't matter which model you look at, whether it's the rat model, the human model, the monkey model. Every time we expose any of these animal models to hyperpalatable food that's highly processed, they all overconsume. They overconsume, they become obese, they become pre-diabetic, and they become diabetic. It's the food combination, high in sugar, fat, and flavor, that makes it hyperpalatable. Now, the fat that they're using, however, is a significant issue also, because they're not using saturated animal fat. They're using vegetable oil, which is a subsidized product. And that vegetable oil has oxidized linoleic acid, which is incredibly toxic to the liver. What's happened is that our hyperpalatable meals are about 44% larger than the average meal used to be. And we've had a much greater activation of our hedonic motivational pathways, which has led to significant overconsumption and periods of anhedonia when we don't get that response. The processed foods contain primarily polyunsaturated fatty acids, omega-6 vegetable oil. The reason why is that you can't tell when an omega-6 vegetable oil is rancid. So appearingly, it can sit on the shelf forever. And the average human being can't discern rancid omega-6. But rancid omega-3, which is primarily a fish product, stenches to high heaven. I can't even be in the same room as a rancid omega-3. But I can't even notice a rancid omega-6. And that rancid omega-6, which is linoleic acid, is highly oxidized. And when it's highly oxidized, it makes highly oxidized LDL, which is ingested by foam cells, which lead to atherosclerosis. And in fact, if you look at some of the cancer studies, you have to use oxidized linoleic acid to pre-treat cancers to get rats precancerous. Without that oxidation of linoleic acid, the vegetable oil, it's very difficult to get rats to get cancer. So it's interesting. Sucrose, which is table sugar, is really a disaccharide. It's made up of 50% fructose and 50% glucose. This becomes relevant because sucrose is rapidly metabolized in small intestine to release equal amounts of glucose and fructose. So your body anticipates that when it sees a glucose, or if it sees a fructose, the other one is going to be there. And in fact, fructose activates some of the glucose enzymes. Glucose stimulates insulin release, and it's rapidly cleared from the bloodstream. You only have about 5 or so grams of glucose that travels in your bloodstream at any given time. Fructose is independent of insulin. It's rapidly taken up by the liver by a first-pass effect, and it's preferentially stored as fat, independently of the insulin secretion. They have different effects in the brain, though. Fructose causes an activation of the reward signal and directly causes dopaminergic release in the nucleus accumbens. Glucose does not seem to activate the reward system and actually has a slightly different response, perhaps with the serotonin system. Now this becomes interesting because when you look at high fructose corn syrup, which is a fundamental portion of processed food, the ratio of fructose to glucose should be 55 to 45. High fructose corn syrup was invented in the 1970s, and it was used initially to replace sugar in prepared food in the mid-70s, which is right around when the obesity epidemic starts to begin. And it's right around the time that the dietary guidelines come out, and it's right around the same time that our mega farms are getting bigger and bigger and bigger, and we're pushing more and more into monocropping. And it's right about the same time that big food is discovering synthetic flavors and starting to implement their use. So I can't tell you which one of these things did it, but we know it's right in this time frame. Now, current sweetened beverages have a different ratio of fructose to glucose. So they've been altered from what we would expect high fructose corn syrup to be, to supposedly a ratio of about 60 to 40. So it contains about 50% more fructose than glucose, much more than what we would expect. But you know what's even more interesting is that when we actually directly analyze these labeled sodas, these sugar-sweetened beverages, they're over 65% fructose. And some of them are 69% fructose. So there's a distortion in what we think we're actually getting. And one might ask ourselves, why would there be such an issue? It's really an intentional and unlabeled increase in fructose. And it seems very unusual. In fact, there are some of them that contain over 69% fructose, which is rather unusual. Soda drinkers are consuming more fructose than most people realized. The average American drinks about 50 gallons of soda, which contains about 34 pounds of sugar a year. My concern is that are the sugar-sweetened beverage companies knowingly activating the reward system, knowing that the fructose is activated, and that is the addictive, compulsive behavior, and is that driving the compulsion to purchase? The side effect of this is excessive fatty accumulation in the liver, and it probably explains our epidemic of non-alcoholic fatty liver disease. It explains our epidemic of metabolic syndrome, prediabetes, and type 2 diabetes. Could this also be the priming of the opioid epidemic? Because we know that if you constantly stimulate dopaminergic flux, no matter what the substance is, it predisposes that patient, that rat, to consume other substances of abuse. When we look at how we treat our patients, we're looking at a combination of treatments. We use a psychobehavioral approach, and we try to extinguish the precedent cues. We use temporal substitution. We try to figure out what are the things that maximize satiety for that individual patient. And our protocols are designed to do that. And so sometimes what we might do is change meal frequency. Sometimes we might use time-restricted feeding. Sometimes we might use substitution. We might use walks to disrupt pattern. We might increase the amount of saturated fat. Those are decisions that we make on an individual basis based upon where the patient is and what the patient needs to accomplish and what are the patient's capacities. Our goal is to reduce the neuroinflammation. And if we can do that by increasing omega-3 and reducing omega-6, that'll certainly improve the outcome. We want to empty the liver of fat and change the insulin resistance that's in the liver. And we want to limit the total feeding or grazing behavior so that we can reduce the overall insulin production.
This has been Dr. Pata with ReverseDiabetes.md. Remember, the information discussed should not be considered specific medical advice and does not constitute a physician-patient relationship. This field is extremely complex and requires a direct physician and patient interaction. Each patient is medically unique and the exact protocol will need to be tailored. If you need further assistance, call our office at 314-481-5000 or send us an email to info@reversediabetes.md.